Hello everyone, my name is Lacey Smith. Welcome to our group's case study on reimbursement and bilateral surgery. Today, we will explore a scenario that showcases how healthcare reimbursement policies can unintentionally shape clinical decisions, sometimes at the expense of the patient's best interests. Our case involved a female patient suffering from varicose veins in both of her legs. After trying conservative treatments like compression stockings and over-the-counter pain relievers for 3 months with no relief, she has been referred for surgery. The diagnosis is confirmed through ultrasound and physical exams. She works as a school teacher, which means long periods of standing up, a significant factor that probably worsens her symptoms. Dr. Cutup recommends surgery but insists on operating on each leg separately 3 weeks apart. However, the patient prefers to have both legs treated at once. Her main concern is minimizing time off work. Her doctor declines her request, citing increased risk related to anesthesia time, potential complications, and mobility during recovery. There's more to consider. Insurance typically reimburses 100% for the first procedure and only 50% for the second if both are done on the same day. This can impact the surgeon's compensation. Spacing out procedures increases overall healthcare cost, from operating room use to anesthesia and follow-up care. This situation reflects a common organizational tension, which is clinical decision-making versus patient preference. While the physician focuses on safety and best practices, the patient values convenience and faster recovery. It raises important questions about how much autonomy patients truly have and how shared decision-making fits into clinical policy. Another issue is how financial incentives shape behavior. When insurance companies reimburse less for simultaneous surgeries, doctors may be motivated to stage the procedures to maximize reimbursement. The system, in this case study, does not reward efficiency or patient-centered care. Instead, it may unintentionally encourage practices that increase costs. The patient's job isn't just a background detail. It is central to her treatment needs. As a teacher who can't sit down much during the day, she is more affected by long recovery periods. Yet, this occupational factor was not integrated into the treatment plan, which reveals gaps in how clinical care aligns with real-world patient needs. Now, let's address a key question. Would Dr. Cutup still choose 2 operations if the reimbursement for the second leg matched the first? Maybe not. If payment were equal, there might be no incentive to split the surgeries. Current insurance models often discourage bilateral surgeries. If reimbursements were the same, many surgeons might prefer to perform both procedures in one sitting. This ends up saving time, money, and effort for everyone involved. If reimbursement was equal for both legs, the benefits would be clear. Shorter hospital stays, reduced anesthesia exposure, and faster recovery for the patient. Surgeons would not face a financial penalty for doing what is best for the patient. Taking money out of the equation, simultaneous surgery would often be the better choice. It is more convenient, requires fewer visits, and supports a more complete and coordinated recovery. Let's focus on what's best for the patient. One surgery instead of two means one recovery period, less emotional stress, fewer disruptions to daily life, and lower costs. It also reduces time under anesthesia, which is safer, especially for patients with other health concerns. Of course, bilateral surgery isn't always the right answer. In patients with certain conditions, such as obesity, advanced age, or a history of blood clots, doing surgery on both legs at once may raise the risk of complications. In those cases, staging the surgeries could be safer. In this scenario, Dr. Cutup may be prioritizing reimbursement over what is best for his patient. This raises concerns about how much financial factors should influence clinical decisions. So, how can this be fixed? The goal is simple. Ensure fair reimbursement for bilateral surgeries when they're medically appropriate so that good care does not come at a financial loss. First, we need equalized reimbursement. Instead of 100% for one leg and 50% for the second, a more balanced rate, possibly 80 to 100% for both. This would eliminate the financial penalty and align incentives with patient-centered care. Second, let's encourage quantity over quantity. Surgeons could be rewarded for avoiding unnecessary operations, maintaining low complication rates, and achieving high patient satisfaction. Third, we need transparency. By tracking outcomes such as infection rates, recovery times, and readmissions, we can identify high-performing practices and hold these providers accountable. Fourth, introduce team-based oversight. Before a surgeon schedules two separate procedures, a review board could evaluate whether that decision is in the patient's best interest. Fifth, bundled payments. Paying one fixed rate for the entire episode of care, which includes pre-op, surgery, and recovery. This promotes efficiency and discourages unnecessary staging. And finally, let's return to shared decision making. Patients should be fully informed about their options, including risks, benefits, recovery expectations. They should be fully involved in their choice of treatment. To sum it up, equalized reimbursement eliminates financial disincentives. Quality bonuses and outcome tracking promote better overall care. Bundled payments reward efficiency. And shared decision-making empowers patients while supporting ethical practice. This case study shows that when financial systems do not align with clinical realities, the care of the patient suffers. With a few strategic reforms, we can fix that. We can put patients back at the center of the decision-making process. Thank you for your attention and have a great day.